I'm going to talk to you about the effect of glenohumeral dysplasia on shoulder kinematics. So we all know that there are muscle vectors in the shoulder, meaning the direction of the line of pull of the supraspinatus, the infraspinatus, and the teres minor primarily. Right. So if you look at a scapula, and this is a normal scapula from a normal shoulder, and you put the humeral head in, right? There's a center of rotation of the humeral head, whereby you get either internal rotation if you're one side, or external rotation if you're on the other side of that center of rotation, or if you're right above the center of rotation, you're going to get straight abduction. So if you look at the supraspinatus, it's pretty much in line with getting straight abduction, which is really what we know of as its function. If you look at the infraspinatus and the teres minor, they're also posterior to the center of rotation, so they're going to give you external rotation, which is what we see clinically. So we noticed a few things, some intraoperative observations. We had a 9-month-old child with about 100 degrees of active abduction, but no active external rotation, severe glenohumeral dysplasia, and there was a plan for spinal accessory to suprascapular nerve transfer. So we went in, we decompressed the notch, and we looked at the nerve. You could see there was one branch going to the supraspinatus and another branch from the suprascapular nerve going to the infraspinatus. When we stimulated the supraspinatus branch, we got internal rotation. When we stimulated the infraspinatus branch, we got straight abduction. And this was at 0.5 milliamps mid pulse width on the checkpoint stimulator. And so the other thing we noticed was in the clinic, we were seeing these children with dysplastic glenoids, which were older, which had a reducible joint. So the joint was in and out. And they reduced when they reduced to the anterior facet, they were able to get active external rotation. So when we held them in the joint, they were able to get external rotation. But when we let them sublux posteriorly, they were not able to externally rotate. And so our feeling was that something is going on. And this is that same child when we did a glenoid osteotomy, and we were able to keep the head in the front, and we were able to restore external rotation actively. And so on the left, you see the pre-op, and on the right, you see the post-op. And you can see how the head is really in line now. And you can see this infraspinatus here is now posterior to the axis of rotate, to the center of rotation. Here, the center of rotation is right here. The infraspinatus is almost in line with it, thereby giving you only abduction. Here's another. So this is essentially the same child as a CT scan. And if you look at it, this is now a deformed dysplastic glenoid. And you can see the glenoid is retroverted, and there's this kind of roundness with a posterior facet. If we put the humeral head in where now the humeral head lives on this child, you can see that the humeral head is posterior. If you look at the center of rotation, and now you put in the infraspinatus, sorry, the supraspinatus is now in front of the center of rotation, so it's going to give you internal rotation. The infraspinatus is now pretty much directly over the center of rotation, and it's going to give you straight abduction. And the same thing for the teres minor, maybe a little bit of external rotation. So very, very different kinematics based on where that head is relative to the rest of the joint. For more information, please visit littlearms.org.